Okay. Okay. Good afternoon, everyone. Welcome to 101st CME talk organizing by Faculty of Medicine, MAHSA University, and the first CME talk in this year 2024. So we have two speakers today and two talks, and the first one is Professor Muhammad Istamul Haq, and he will be talking on cardiovascular disease prevention. So let me introduce Prof. Haq. Uh, he is a successful clinical and interventional cardiologist with more than a decade of experience with both general and interventional cardiology, having a lot of skills, experience in various diagnostic procedures, including ECGs, Holter monitoring, exercise stress testing, echocardiogram, coronary angiography, and PTCA, stenting, and numerous other cardiac diagnostic procedures. And he worked from 2004 to 2023 in Dhaka in Skinder Women's Medical College and Hospital Cardiac Center. After that, from since 2014, the professor is working in Department of Medicine and Faculty of Medicine, MAHSA University. He completed his MBBS diploma and a Doctor of Medicine in Cardiology, everything in Bangladesh. And after that, he had a huge training and professional development activities around 19, and it's in a different countries like Singapore, Vietnam, South Korea, Istanbul, Turkey, Japan, France, Sri Lanka, India, then USA. I think almost all countries he traveled and developed his extra skills, and that shows his dedication in his field. And is also affiliated to different societies, like member in Bangladesh Medical Dental Council, Bangladesh Medical Association, and Bangladesh Cardiac Society, Bangladesh Society of Cardiac Intervention, and associate fellow of American College of Cardiology. So with this a long introduction, I mean, put in a very short, it's having a lot of achievements, and I would like to introduce Professor Muhammad Istamal Haq to talk on cardiovascular disease prevention. Thank you, Prof, and the floor is yours. Thank you.
Okay. Respected Dean, Deputy Deans, Datus, Professors, my colleagues, Assalamu alaikum and good afternoon. Thank you, Prof, for your good introduction to me. Thank you. So today I'll be discussing a very popular common topics. Everyone knows this, but still this is just for reminder for all of us. So cardiovascular disease. So normally we are thinking probably this is the only coronary artery disease, but actually this is a broad term. When we are telling cardiovascular disease, it means that the coronary artery disease, cerebrovascular disease, atherosclerosis, blood pressure, heart failure, so many things includes this cardiovascular disease. And this cardiovascular disease are the number one killer and cause more than 33% of all deaths. So this is a major cause of the disability, health and human suffering. Social and economic losses are high, and cardiovascular disease causes 25 to 30% of all medical expenses. So this CVD is an important cause of the morbidity and mortality also in Malaysia. The prevalence of the common cardiovascular risk factors like the hypertension, smoking, hypercholesterolemia, diabetes, overweight, and obesity in Malaysia is high and shows a rising trend in Malaysia. Okay, so this is almost 33% of all death, which I mentioned, and 20.5 million deaths in every year due to this cardiovascular disease. 80% of the premature deaths from the cardiovascular disease are just preventable by making small changes to our lifestyle, what we eat and drink, how much we exercise, and how we manage stress. We can better manage our heart health and beat this cardiovascular disease. Okay. So this cardiovascular disease, uh, so this is covering the coronary artery disease, cerebrovascular disease, deep vein thrombosis, pulmonary embolism, congenital heart disease, rheumatic heart disease, that is the valvular heart disease, also the peripheral arterial disease. Okay, so other than this, also there is atrial fibrillation, aortic disease, cardiomyopathies, pericardial disease, including pericarditis. Also, Chagas disease can cause this, which is causing the reversible damage of the heart. All this includes within the cardiovascular disease. Okay, and the pathophysiology, this is very common. This is the similar pathophysiology. This is mainly due to the cholesterol. Okay, so this cholesterol, so this is starting, there is some myth that this is starting from old age. But actually now, it is established that it starts from 2 years of age. So child obesity is now another issue. Okay, so starting from the 2 years, so there is foam cell, fatty streak, intermediate lesion, atheroma, fibrous plaque, complicated lesion. So this first decade, third decade, fourth decade, this way, this is just producing. So you can see the changes. Foam cells, 10 years there is fatty streak, 20 years there is intermediate lesion, 30 years atheroma, 40 years so fibrous plaque, also 50 years. These are the complicated lesion, also rupture, which causing actually all types of the coronary artery problem, coronary artery disease. So this prevention of this cardiovascular disease. So this is we can just discuss this way. One is the primary prevention. So primary prevention is non-disease state. Non-disease state. So how you can do just awareness and identification of the cardiovascular risk factors. That is the like this smoking, overweight, obesity, excessive alcohol consumption, and physical inactivity. So you can do just like this smoking cessation, vascular health checks, weight management service, and alcohol brief intervention. Okay, this is how we can manage the primary prevention. Secondary prevention, that is mainly post diagnosis of the cardiovascular risk condition is already diagnosed. Okay, so how we can do? Just we can do this hypertension, dyslipidemia, diabetes. That is actually we have to treat the condition and we have to prevent the next episode. We have to prevent the next episode. Another is the established cardiovascular disease. Already established, there is problem. So that is the tertiary prevention. So we have to prevent of a second cardiovascular episode and reduction of the complications. This one is the reduction of the complications and premature death. Okay. So that is the coronary heart disease, MI angina, cerebrovascular disease, stroke, TIA, peripheral arterial disease, deep vein thrombosis, pulmonary embolism. Okay. So this what we can do, just dispensing the prescribed medications, lifestyle advice. Okay. So smoking cessation, weight management service, alcohol, these are the things we can do. These are the tertiary prevention. So now just we can discuss this way, this prevention. So the first point just we can emphasize according to the American Heart Association recommendation, just you have to know our risk. What is our risk? Okay, this is the most important part to prevent the cardiovascular disease. So this is the first. Second point, that's eat a healthy diet. healthy diet, then physically active, watch your work, then the live tobacco free, manage conditions, take your medicine, be a team leader. So first we can start with the risk. Okay. So there is certain factors that increase risks. We know that smoking, kidney disease, family history, but many factors, many risk factors can be improved with lifestyle changes. With lifestyle changes. So these few risk factors, we can't do anything. Okay, we can't change. Age cannot do anything. So age, so there is previously we are telling this is the for female more than 65 years, male 55 years. Now we are telling the ages for the male more than 45 years, female for 55 years. But recent recommendation on is the male 35 years, female more than 55. This is due to the lifestyle change, food habit. This is now reducing the age, and we can't do anything here. So female, male is more predominant of the cardiovascular disease, ethnicity, family history. So can't do anything. But there is few things. So we can change. We can change. So behavioral factors like this, physical inactivity, insufficient physical activity, salt, high sodium intake, high alcohol consumption, tobacco smoking. We can change, we can stop, we can modify. Metabolic factors, blood pressure, then the diabetes, fasting blood sugar, that is the body mass index, high low levels of the lipoprotein LDL cholesterol, and also the environmental factors, that is the air pollution, water pollution, sound pollution. These are also influencing the just progression of the cardiovascular disease. So this we can do something. Let's discuss these things one by one. Okay. So now see the cardiovascular disease, overweight. Overweight. So probably the Malaysian people, sixth position in the world now, the ranking of the obesity probably. So overweight, this is just you see the 35% causes of the cardiovascular disease. Age related 22%, smoking 16%, okay, and not exercising, this is also 11%. This is also 11%. So now go to the eat a healthy diet. Healthy diet. So this is actually the another very important part. So this healthy diet to maintain it is not so easy. Not so easy. So, but actually, for the prevention of the cardiovascular disease, so we have to plan, eating plan around the vegetable, fruits, whole grains, legumes, nuts, plant-based proteins, lean animal proteins, and fish. And we have to limit the sweetened drinks, refined carbohydrates, added sugar, and processed meats, sodium and saturated fats. And also we have to avoid the trans fat. Okay. So this foods, so these are the calories, quantity. Quantity is important. Okay. Quantity is a very important part. So the calories so should be limited 1600 to 3000 per day. So there will be according to the based on the age, sex, activity level. So focusing on nutrient dense these things. Timing. So timing, time restricted eating with a 14 hours fasting interval has benefit for weight loss and potential cardiovascular prevention. You know the fasting and also intermittent fasting. Okay, so this is now a very important points for the control of the obesity, for the control of the overweight, so many things, and this is a very important part now. Fasting, intermittent fasting. So this is another thing. Then the quality. So quality, there is Mediterranean diet. Okay, more or less balanced diet you can tell. DASH diet, that is you can tell the diet approaching the stop hypertension. So these are the diets. So This fiber supports microbiome diversity, reduce these are inflammation, and another is the patient engagement. Patient may be preferred to the cardiac, cardiologist, also cardiac rehab, also dietitian, shared medical appointments, so education supports. So these are the few important parts. Okay, so about the fat, so we have to know few things. Fat, these some are good fats, some are the bad, and some are ugly. Okay, so good fat we can tell this mono unsaturated and polyunsaturated. So these example, these are mainly plant-based liquid oils, nuts, seeds, and fatty fish. So oils such as we can tell the canola, olive, peanuts, sunflower, okay, and this avocados, fatty fish, and nuts and seeds. So this can lower bad cholesterol level. That is the LDL cholesterol, can lower the risk of the heart disease and stroke, can provide essential fats that your body needs but cannot produce itself. So these are the monounsaturated, polyunsaturated. Saturated, this is mainly the beef, pork, and the chicken fats, red meats. Okay. Then the cheese, then the butter, tropical oils. Okay, most saturated fats come from animal sources, including meat and dairy, and from tropical oils. Okay, so this saturated fat can raise bad cholesterol level, can raise good cholesterol level, can increase risk of the heart disease and stroke. Okay, this is the saturated fat. You have to be careful this one. And third one is the hydrogenated oil and trans fat. That is the processed food made with partially hydrogenated oils. These are the partially hydrogenated oils, food, fried foods, some baked goods, stick of margarine. So this can raise the bad cholesterol level, can lower the good cholesterol level, can increase risk of the heart disease and stroke, and can increase risk of the type 2 diabetes, because this fat is everywhere. So this cardiovascular disease, this stroke, this peripheral artery disease are related to these fats. So you have to have a good idea about this fat, which is good fat, which is bad fat, which is useful. So you have to have a very good idea. Okay, so these are the saturated, monounsaturated, and omega-3 fatty acid. This is from the fish oil. This is the heart healthy. Heart healthy. And cholesterol, so this is same thing, so just related to the fat. So 2.6 million death, and is implicated heart disease. Okay, 2.6 million death. Okay, so this is the LDL cholesterol. So good cholesterol is bad. This is the bad cholesterol. This is the good cholesterol. Okay, and triglyceride. Triglyceride also most common type of the fat. This stores excess fat from your diet and it's harmful body. And Malaysian people actually this triglyceride is also high. Probably this is taking the rice, also different types of the juice that is causing this more, increased level of the triglyceride. This Malaysian people. Okay. Okay. Then benefits of the reducing cholesterol. So 10% reduction of the blood cholesterol produces 20 to 30% decline of the coronary heart disease death. If you are reducing 10%, so it affects 20 to 30%. All adults more than 20 years must get tested. If normal, test again after 5 years. If elevated, work towards normalizing the level with lifestyle changes and other drugs. Okay, so more than 20%. Better you have to check what is the cholesterol level. What is the cholesterol level? So these are the things we already discussed. So better try to avoid limit egg yolk, fatty meat, organ meat, that is liver, butter chicken, butter fried fish, milk fat. These are the very popular things. Ghee, butter, cheese, malai, rabdi, ice cream. Hidden fat like bakery biscuits. So better you have to limit or avoid these foods. Okay. Okay, so healthy diet characteristics. So these are some recommendation here that salt must be less than 5 gram total salt, 30 to 45 gram fiber per day, more than 200 gram fruits, 2 to 3 servings, more than 200 gram vegetables. And this is one of the recommendation of the European Society of Cardiology. So another recommendation here that fish is recommended on to 2 times per week, 30 gram unsaturated nuts per day. Okay, consumption of alcohol should be limited to a maximum 100 gram, those who are taking. And the sugar sweetened beverage such as soft drinks and fruit juices must be discouraged. Red meat should be reduced to a maximum 350 to 500 a week. A particular processed meat should be minimized. Fish is recommended on to 2 times per week in particular fatty fish. Okay. So about this salt, so this is a very creating so many problems for our health. You see the high sodium intake causing the vascular damage, oxidized stress, hormonal alterations, immune systems, gut microbiome, finally causing the organ damage. So should be very careful about the salt, table salt, salty foods. Should be very careful about this. Okay. So these are the few pictures. So making the simple eating pattern which can help us, our family healthy. So these are things, fish, other things. Okay. Also, you can see heart healthy diets with the fish, fruits, banana, vegetables. So many things given here. Okay. Next is the most important is the be physically active. Adults should aim for at least 150 minutes moderate intensity aerobic activity or 75 minutes vigorous activity each week. So we are more or less sedentary worker. We are not doing the physical activities minimum. So this is very important for us. Okay. So if we are those who are active, we have to increase our intensity for more benefit. If not active, get started by sitting less than and moving more. Okay. So this physical activity. Okay. So physical activity benefits. So how it benefits? Improve sleep. Sleep is a very big problem, mainly those who are now 40s, 50s. So physical activity benefits improve sleeps, maintain healthy weight, manages stress, improve quality of life, and reduces the chance of type 2 diabetes. This is 40%. So physical activity reduces the diabetes chance 40%. CVD disease, cardiovascular disease 35%. Falls or depression 30%. Joint and back pain, this is 25%. Cancers, colon, breast 20%. So some is good, more is better. Make it start today. It's never too late. Every minute counts. Okay. So these are the very important few suggestions here given. So moderate means cycling, swim. These are the moderate. Vigorous means maybe just this is the sports, run, stairs. These are the vigorous exercise. Okay. So at least 150 to 300 minutes moderate in aerobic physical activity, and if it is vigorous 75 to 150, this is the another recommendation or equivalent combination throughout the week, another. And for additional health benefits, more than 300 minutes moderate intensity aerobic physical activity or more than 150 minutes vigorous intensity aerobic physical activity. This is for the additional health benefit. Okay. So we can try with this way so that we can keep our health. So we can control the risk factors. Okay. So the simple walking for a healthy heart. Okay. Just walk. Complicated exercise machines or sweating it out in gym not essential. This is not essential. Just work. Just work. Just work. And the problem is we are spending a lot of time. Lot of time screen. So the amount of time spent being sedentary, particularly recreational screen time, we must limit. Must limit. Okay. This is taking a lot of time now. Now just going to the weight. Going to the weight related to the BMI, body mass index. So this body mass index, you know how to count this body mass index. Okay, this is the method calculating the body mass index. So body mass index, so there is a, so you can see this index. Below 18.5 is the underweight. Normal is 18.549 normal. Overweight 25 to 29.9. Obese 30 to 34.9. More than 35 extremely obese. So you have to check our BMI. We are normal, overweight, obese, or extremely obese. So we have to check ourselves these things. Okay. So this is the body mass index. And actually, if we are reducing the body mass index, say we are obese, we are overweight, we are extremely obese. Okay. So if we are reducing the body weight, so it will reduce the blood pressure, reduce the blood lipids, reduce the blood glucose, reduce the insulin resistance, also inflammation. Okay, so there is given some data 10, 0 to 5, 5 to 10, 10 to 15. So BMI reducing, this is also very important, those whose BMI is high. Okay, so there is one recommendation of American Heart Association. Calculating BMI is recommended actually or more frequently to identify adults with overweight and obesity for weight loss consideration. We have to check routinely our BMI. It is reasonable to measure waist circumference to identify at higher cardiometabolic waist. Actually, we have to know this one. What is the how to calculate this waist hip ratio? What is the relation with the coronary artery disease or other cardiovascular disease? So I will be telling few words about this waist. Okay, so it is recommended that overweight and obese people aim for a reduction in weight to reduce blood pressure, dyslipidemia, and type 2 diabetes, thus improve the cardiovascular risk profile. Okay. Okay, so just few words about the obesity. So when you carry too much fat on your body, placing on your health, so obesity has been linked to heart disease, blood pressure, cholesterol, diabetes, heart attack, stroke, linked with the obesity. Okay, so this is very important for our health issue, obesity. So these are the cardiometabolic risk factors and outcome due to the obesity. Okay, so this is the depression, damage, hypertension. These all are the complication of the obesity. I'm going fast. So now, this obesity, there is pears and apples. Pear shapes is the store fat in the hips and thigh, just below the surface of the skin. An apple shaped store body fat around the abdomen, chest, and surrounding internal organ. So these two type of the obesity, just we have some knowledge so that we can assess ourselves. So you see this one. This is the apple shaped. Mainly the fat is in the abdomen. The pear shaped fat is in the lower part, below the abdomen. Okay, below the abdomen. And this one, pear shaped, okay, below the waist and above the waist, this is the apple shaped obesity. This is the apple shaped obesity. So this one, so more weight above the waist, this is the more weight below the waist. Okay, more weight below the waist. So these two types of the obesity. So these are the visceral fat, subcutaneous fat. These are the visceral fats. These are the visceral fats. Okay. So this waist hip ratio, this is the another indicator to just calculate the risk of the heart disease or cardiovascular disease. Okay. So for the female, 0.8 or below, low risk. So this is moderate risk, 0.85 and over is the high risk. And for men, this is 0.95, 96 and 1. So waist hip means, this is the narrowest point just in the abdomen, and hip is the widest point, this ratio. So this waist hip ratio, this is actually, there is a correlation with the coronary artery disease, and higher the ratio, more chance of the coronary artery disease. And actually my thesis in my Doctor of Medicine was this topic, waist hip ratio correlation with the coronary artery disease. Okay, so this is also another indicator for the cardiovascular disease, coronary artery disease. Okay, next is the uh, tobacco. Tobacco, I think everyone knows this, tobacco. So we must stop. There is no way, must stop, because so many problems, so cancer, the heart problem, the hypertension, so many things, everything related to this. So increase blood pressure, decrease the HDL, good cholesterol, damages artery and blood cells, increase the heart attacks. Cigarette smoke containing more than 4,000 chemicals, and 200 of these chemicals are poisonous. Okay, so this is the tobacco. So the risk of the heart attack start decreasing within 24 hours quitting smoking. If I stop smoking, so start decreasing within 24 hours. Within 1 year quitting, and coronary heart disease risk decreases significantly within 2 hours. It reaches the level of non-smoker. And smell and taste improve within days. Within 3 months of quitting, the smoker's cough disappears in most people. Most people. Okay. So heart needs food, not the tobacco. Okay, must stop, quit. Okay. Then few other condition, few other disease condition we have to manage. Okay, so these are the hypertension, diabetes, also few other conditions. Just I will tell shortly. Okay, so hypertension. Hypertension, 1.28 billion adult age 30 to 79 years worldwide. Okay, and 46% of the adult hypertension unaware about that. Almost half of they are already hypertensive, but they don't know they are hypertensive. Okay, and less than half of the adults, 42%, hypertension are diagnosed and treated. Okay, so approximately 1 in 5 adults with hypertension have under control. Hyper major cause of the premature death worldwide, and 47% of the coronary disease world disease attributable to high blood pressure. Okay, so you see this one, just rising this. So 20 millimeter of mercury pressure rising, increasing the 50% of the heart disease and stroke, and decreasing the 2 millimeter of mercury, decreasing the 10%. So pressure control, hypertension control is so important. Okay, very important, this control. Okay, so there is a definition, or there is the this recommendation is, so this is one of the latest recommendation. We can follow this one, that now previously we are telling below 140/90, but now is the normal is below 120, and diastolic less than 180. This is normal. When it is going to 120 to 129, this is the elevated. When 130 to 139, this is the stage 1, and diastolic 80 to 89, and high blood pressure is stage 2, 140 or higher, and diastolic 90 or higher. Okay, and hypertensive crisis, so higher than 180, and diastolic more than 120. This is the classification suggested by American Heart Association. So we can see this one, but there is also European Society of Cardiology. There is another recommendation, so we can follow better this one. Okay, classification. So this we can just control our blood pressure. There is some non-pharmacological intervention. These are important. Okay, this is one is the weight loss, another is the heart healthy dietary pattern, sodium reduction, that is salt, dietary potassium supplementation, increase physical activity program, and alcohol limitation. So this way we can, without medicine, we can reduce our blood pressure. Okay, so these are the physical activity, aerobic, dynamic resistance, isometric resistance, and alcohol consumption given here, and how much they are reducing. This is given here. This okay, this is also another. The weight loss, healthy diet, reduce intake of the dietary sodium. So how they are decreasing 5 millimeter, 11 millimeter, 60 millimeter. Okay, this way just is reducing the pressure. So these are very important part. And this DASH diet for the hypertensive patient, this is another important thing. DASH means dietary approach to stop hypertension. So most important is the grain. Grain, this is the full grain foods mainly. So 6 to 8 servings per day. Fresh fruits and vegetables, 4 to 5 servings of each day. Lean protein, 6 or less serving per day. And the legumes and nuts, fats and the sweets, this you have to limit. We have to limit that one. And low fat diet, this is 2 to 3 servings. There's also there is so many recommendation of this dash. So for the hypertensive patient, we have to avoid the sweet, avoid the sugar, saturated fat. That is the this baked food, candy, bars, ice cream, fruits, okay, fatty meals, full fatty dairy products, palm oils, processed food, alcohol. Recommended fruits, vegetable, fresh, frozen, cooked, boiled, lean meat, poultry, eggs, fish, and these are the dash diet. Okay, this we can. This is recommended. Okay, this is for the hypertensive patient. And normally, those who are hypertensive, because we are those who are ages above 30, 40, so we have to do some routine test, because more or less we all are physician, and physician ourselves we are actually most neglected, means we ourselves not doing our checkup, okay, including myself. So we are not doing the regular checkup, regular investigation. So we need to do our investigation routinely, like the hemoglobin, fasting blood sugar, HbA1c, fasting lipid profile, electrolytes, uric acid, okay, serum urea, creatinine, liver function test, urine for the routine examination. This we can do routinely for to check our health condition. Basically, if we are hypertensive, these are the basic tests we need to just do periodically. Okay. So recommended the blood pressure. What is the recommended blood pressure? So this is also European Society of Cardiology on recommendation. So this age group, 18 to 69, 120, 30. If diabetic, 20, 30. Chronic kidney disease, 140 to 130. Coronary artery disease, 120 to 130. And stroke patient, this. Okay. Over 70, less than 140, down 130 tolerated. Okay. And diastolic. So this is one of the recommended target ranges of office blood pressure. Okay, so this given the management of the hypertension. So this management, this is normal blood pressure. This is mainly the lifestyle. So elevated, this one pharmacological we can try, but stage 1, stage 2, we have to go for the pharmacological management mainly. Okay. Okay, so these are the some combination. Normally, we can start with the SC inhibitor or receptor blocker, sometime giving the calcium channel blocker also. Also, some cases associated with the heart failure or heart condition, sometime giving the beta blocker. But age when is above 55 or 60, calcium channel blocker is a very good drug. So sometimes if not controlling, we are giving the combination 2 drugs, 3 drugs, sometimes the resistance cases. So also a combination of the 2, 3, 4 drugs we are giving to control the hypertension. So control of the hypertension is a very, very important thing to reduce the so many accident. This is the complication of the high blood pressure. Okay. Next is the diabetes. So diabetic person have 2 to 3%, 3 times higher risk of the heart attack. So there is another name. Diabetes means IHD equivalent. That is, if there is diabetes, must be heart problem. So diabetic people must be very careful about the heart problem. Okay, this is 2 to 3 times higher risk of the heart attack or stroke. The diabetic is more likely to die a heart attack than a non-diabetic. More than 80% die from the heart disease. This is for the diabetes. Okay. Risk of the sudden death from a heart attack for a diabetic is the same as that of the someone who has already had a heart attack. Okay. That's why so diabetic patients should be very careful about the cardiovascular disease prevention. So this type 2 diabetes, dyslipidemia, hypercoagulation activation, metabolic dysfunction, environmental pollutant. These are the physical inactivity, poor diet, smoking, obesity. This side the cardiovascular disease. This side endothelial, arterial stiffness. These are the so related to this diabetes, mainly type 2 diabetes. So this diabetes causing stroke, eye, diabetic retinopathy, also kidney nephropathy, peripheral neuropathy, also this diabetic bone disease, fatty liver disease, heart disease. So all the organ, this is affected by the diabetes. So we should check the diabetes routinely for our diabetes. So there is normally we are checking the HbA1c. So HbA1c should be, this is below, there is some range, pre-diabetes, there is some range, diabetes. So should be below 5.7. And there is fasting blood sugar, there is after 2 hours random blood sugar. So we have to check properly, routinely our diabetes. And treatment of the diabetes also, there is non-pharmacological, there is pharmacological associated with the exercise and other things. Okay. Okay, next I'm going to the mental health. Mental health. So heart rate can become irregular. Blood pressure can increase. Fat cells become converted to bad cholesterol and platelet dysfunction occurs. So how come mental health causing this? Okay, mental health. So the way you handle negative emotional states also matter. So stress, anxiety, and depression have real physical effect on your body. Heart rate, blood pressure, fat cells, platelets. Okay. So this mental health causing also affecting this, also increasing this cardiovascular disease risk factors. Okay. So reducing the stress. These are the few tips. Okay. So sleep. So very important sleep. Okay. Then the get outside meditation. So different religion, different way of the meditation they can do, and the reading, think positive, exercise. These are the things to reduce the stress. So everyone has the own way to reduce their stress. Okay, so we have to try. There is so many things. So we have to try to reduce our anxiety, our try to keep it a good mental health in our own way. Also can take help to others, those who are expert to this field. Okay, and then is the medicine. Take your medicine. If you are hypertensive, if you are diabetic, if you have some other complication, so taking medicine, this is very important. So very careful about taking medicine. Okay, medicine. So many medicines. Sometimes we need to take. So you have to take it routinely. Cannot miss the medicine. Okay. Another issue. This is one of the recommendation to prevent the cardiovascular disease. Aspirin. Aspirin. Low dose aspirin. Normally, low dose aspirin is 75 milligram or 100 milligram. Okay. So this aspirin, there is different recommendation. Okay. So there is some study showing there is the benefits, and some study showing also some side effects, mainly the bleeding. Okay. So there is people also there is benefits also there is few complications. Still overall, so there is benefits also. So to prevent the cardiovascular disease, also we can take the low dose aspirin. But this aspirin for the old people above 70, This is actually, we have to be very careful. We have to be very careful because this aspirin also sometimes may cause, with the hypertension, may cause brain hemorrhage, other bleeding problem. So, there is so aspirin. There is some safety, efficacy. Also, there is some bleeding risk. Okay, we have to check both the sides. Okay. Okay, about the alcohol. So, alcohol, actually, say not, no to the alcohol, better. Also, if you cannot control, cannot those who are can take according to the religion, but should be, this is difficult to control. Okay, so say no to the alcohol. Okay, these are the new few factors. Air pollution. So air pollution, this is one of the factor for the prevention of the cardiovascular disease. How does the air pollution affect your heart? How does? So teeny particles travel into the bloodstream. They damage the inside walls of your blood vessels, causing them to become narrower and harder. So this causing restricted movement of the blood vessels can increase your blood pressure. Your blood is more likely to clot, which can lead to heart attack or stroke. Normal electrical functioning of your heart is affected, which can cause abnormal heart rhythms. If you already have heart disease, and short-term exposure of air pollution increases your risk of heart attack and stroke. Okay, so air pollution. I think Malaysia air pollution is not a important issue, but in Southeast Asia, there is few countries. This is a very big issue. This air pollution. Okay, so this air pollution. This is the another important thing. So this is causing 29%. Okay, probably another one. Okay, so air pollution. Okay, then water pollution. Water pollution can indirectly contribute heart disease. Water pollution can introduce various contamination in the drinking water sources, including heavy metals, that is the lead arsenic, chemicals, that is pesticides, industrial pollutants, and microbial pathogens, bacteria and viruses. Okay, so this air pollution, water pollution, and also sound pollution. Sound pollution. 5 decibel increase in the average 24-hour noise level was associated with a 34% increase in the heart attack, strokes, and other serious heart-related problems. Okay? So sound pollution. This is another important thing for the cardiovascular disease. Sound pollution. Okay, and there is few new other things like micro and nanoplastics. These are the new cardiovascular risk. Okay, this review unveils that micro and nanoplastics can disseminate and aggregate in the circulatory systems, threatening the cardiac function, causing toxicity on microvascular sites. Okay, so this micro and nanoplastics. Okay, so this also may cause these cardiac problems. Okay, and emerging risk factors. One is the coronary artery calcium, C-reactive protein, lipoprotein A, carotid intima media thickness, homocysteine, which causing the young people cardiac problem mainly, lipoprotein associated phospholipase A2, radiation exposure, okay, COVID-19. These are the emerging new risk factors. These are the emerging new factors. Okay, so there is some calculation atherosclerotic cardiovascular disease. So we can just calculate. There is some table. There is some measurement. We can tell the risk factors. I can assess the risk factors of this cardiovascular disease. So this is this if we are just calculating the previous one, so we can tell this if it is say 0 to 5% low risk, borderline 5% to 7.5%. If it is, this is the 10 years, absolute 10 years, atherosclerotic cardiovascular risk, intermediate risk 7.5 to less than 20, and 20 or more, this is the high risk. So clinician patient discussion considering risk enhancing factor and net benefit of the therapy. So this you can just suggest the lifestyle modification, lifestyle and drug therapy, okay, different way. So this is sometime we can assess, we can calculate, okay, we using this. So finally, 10 regular health, so finally, regular heart health checks, okay. So this is a very important thing we have to do. So this is for the high risk groups, moderate risk groups, and also low risk groups. So we have to do this regular health checkups. These are very important thing. Okay. So prevention of the cardiovascular disease, just in summary, cholesterol. So assess this, and also then is the high blood pressure, control physical activity, and then is the aspirin. So type 2 diabetes, this is control, diet, tobacco. These are the most important things what we discussed. And lastly, 10 steps to protect our health. 10 steps. So this is, we can start from here: move more, be smoke free, maintain a healthy weight, drink no or less alcohol, reduce stress, manage your cholesterol, manage your blood pressure, manage your blood sugar, see your GP or a heart health check. Okay, follow a heart healthy eating pattern. Okay, so this is my discussion. Thank you. Thank you. So if you have any questions, so can discuss.
Thank you so much, Prof. It was an excellent presentation and very useful to every one of us. Of course, this today we targeted to more clinicians and the doctors, but this talk is, I think, it is useful for every common individual, from staffs, students, and everyone, and normal all the people. So I think it would be nice if we organize another talk for all people. If you kindly agree for this one. And yeah, actually you covered from the basic, the knowing the knowledge about the thing, diet, physical exercises, body, BMI, alcohol, and tobacco free, managing the conditions, medicine to take, and also regular checkups, everything. Excellent 10 steps, Prof. Thank you so much. It's very enlightful, your presentation. And I would like to ask anyone if they have any questions, please put your questions in the chat box, so we can ask Prof to clarify anything. Prof Nizamuddin said it's a very informative. So
Thank you.
yes, definitely, Prof. It is very informative.
Thank you, Prof.
Any questions to Prof? If you want to ask, please leave your question in the chat box. Okay, thank you so much. Thanks for everyone to joining the talk and encouraging. And thanks, Prof, once again for the wonderful talk. And then we would like to invite the second speaker today. Okay, she's here. So today the Dr. Menega is second speaker of the day. She's completed her bachelor's, master's in biochemistry and genetic engineering from University Putra, Malaysia. and she enrolled for 5 years PhD program under a mixed scholarship and completed in structure biology. And following that, she worked as a postdoc at University of Tokyo for a year on structure-based drug designing, specifying on G protein coupled receptor, and then another 1 year in NUS, National University of Singapore, working on X-ray crystallography. So, with this small introduction, I would like to invite Dr. Menega to talk about the structure-based drug design. So, Dr. Menega, the floor is yours.
Thanks, Prof. Suresh. Respected deans, deputy deans, professors, doctors, and to all my colleagues, good afternoon. As Prof. Suresh mentioned, I'm going to talk about structure-based drug design today. Uh, my background is on structural biology, and during my postdoctoral research fellowship, I have done a few structure-based drug design for proteins like G protein coupled receptor and DNA binding proteins. So, based on that, today I would like to talk about uh, basic information on drug discovery. I don't think it's going to be something new. I'm pretty sure everybody have heard about drug discovery a lot. So I'm just going to briefly mention about what is drug discoveries and what are some basic steps which is involved in traditional drug discovery technique. And I will also talk about computer aided drug design and structure based drug design. I will not mention too much on the softwares and the tools because it's kind of too much mechanical. So I will be focusing on the principles just to say how it is advancing. And I will focus on structure-based drug design in GPCR, the advancement of structure-based drug design in GPCR, and finally, I'll talk a little bit on the future perspective of structure-based drug design. Okay, so drug discovery is an inventive process of designing or discovering new chemical compounds. Mostly, these chemical compounds are small molecules, and they can act as a drug against specific diseases. So the process of identification of medication against any disease involves passage through various sequential stages. And this diagram here, it shows the basic process, the basic steps involved in traditional uh, drug discovery process. So the first stage is target identification. Target identification, it's usually done by studying and understanding the disease spaces by using various genomic and proteomic approaches and identifying the target, which is mostly protein that could alter the disease conditions. Most of the drugs which is available in market right now, the targets are usually proteins, and some of it it's targeting DNAs or RNAs. The second stage is identification and optimization of lead compound. Lead is the compound that binds to the target of our interest and it alters its function, thereby altering the disease condition. The third stage is, of course, clinical trials, and the final stage is on FDA approval and marketing. So, in today's talk in terms of structure-based drug design, it will be focused only up to lead compound identification and optimization. because right after that, the clinical stage and FDA approval, it's usually the same. It doesn't matter if it's a traditional drug discovery process or it's a computer-aided drug discovery process. So, computer-aided drug discovery process. A computational approach are useful tools to interpret and guide experiments to expedite the drug design process. It doesn't matter if it's a small molecule or antibody. So, structure based drug design and ligand based drug design are the two general types of computer aided drug design which is currently existing. Structure-based drug design methods usually analyze the macromolecule target. They analyze the three-dimensional structural information, mostly proteins or RNA, or the complex of proteins and RNA, to identify the key sites and the interaction that are important for their respective biological functions. So these key sites are usually the active site of the protein. So this kind of information can then be utilized to design the drugs that can compete with essential interactions involving the target. So whether they act as an antagonist or an agonist. Ligand-based drug discovery, it starts with either a single compound or set of compounds which is known to be potent against a target and based on knowledge of structure activity relationship, potency, and other important properties are improved by designing appropriate analogs. So most of there are not many, but there are quite a number of drugs which is currently in market, which is designed based on computer aid drug design, and most of it are ligand based drug discovery, and maybe one or two is structure based drug discovery. So this diagram, it illustrates the basic workflow for computer-aided drug design. And so the process starts with a biological identification of a putative target to which ligand binding should lead to antimicrobial activity. So in structure-based drug design, the 3D structure of the target can be identified by either X-ray crystallography or nuclear magnetic resonance or NMR spectroscopy or even using homology modeling. And currently, one of the recent advance in structural biology is the solution of structures by cryo-electron microscopy, which allows the solution of the solution of 3D structure when the protein is in the solution state and not when the protein has to be crystallized. So this lays the foundation for computer-aided structure-based drug design screening. So with available structures, then the leads can be identified and optimized using MD simulations like docking, MD simulation, and target-based pharmacophore. In terms of ligand-based drug design, it is used in the absence of the target 3D structure, with the central theme being the development of structure-activity relationship, from which the information on modification of the lead compound to improve activity can be obtained. So usually in lead-based drug discovery process, there will be a lead which is already established, and this lead will usually be used as a template to find more potential leads and study their structure activity relationship. So information from the computer-aided drug design methods is then used to design compounds that are subjected to chemical synthesis and biological assay. So this are some examples of drugs which is FDA approved and are currently in market, which were all designed based on computer-aided drug design. Out of this, the HIV-1 and HIV-2 based drugs are designed based on structure-based drug design, but the rest are all designed based on ligand-based drug design. So, as I mentioned, I will be mainly focusing on structure-based drug design for today. So, structure-based drug designing is one of the most effective and powerful process which governs the entire drug discovery process today. So, technological advancements in experimental methods such as NMR, X-ray crystallography, and cryo-electron microscopy have allowed structure-based drug design to obtain a vital position in medicinal chemistry. So, owing to the dramatic increase in the availability of 3D structures of protein targets, both soluble and complex membrane proteins, and the rapid advancement in computational chemistry, structure-based drug design has become an integral strategy for both lead generation and lead optimization. Um, the information about the target of small molecule, genetic information with their sequences, binding information, cytotoxicity, absorption, metabolism, excretion data, and other important biological information. This information serves as the most efficient sources for accelerating the drug discovery process through computer aided. So, following some advantages of structure based drug design over traditional based drug design. So, in structure based drug design, hundreds to thousands of ligands can be described and it can be virtually screened as potential drug leads without the need for initial purchase or synthesis. So, as long as we have the structure of the protein and the chemical structures of the small molecules, then we can do docking and MD simulation to find the drug, uh, potential drug which can bind to that specific protein. And it also the speed of structure based drug design process is also rapid relative to in vitro screening, and the cost of this process is also relatively low when we compare with traditional based drug discovery process. So, I will briefly talk about the steps which are involved in structure-based drug design, which includes first identification of the drug target, followed by determination of target structure, identification of binding site, computational drug design methods, and evaluation of potential lead candidate. So, A drug target or a receptor is a macromolecule that is critical for a disease condition to happen. So the identification of a drug target, it starts with the understanding of the structural biology of that particular target. Function prediction, pathway information, disease association, and structural data. All these things need to be considered when we are choosing the drug target. So different bioinformatic tools are currently available and are used to gather this information, helping to choose the potential drug target that is critical for the disease function. So the objective of the objective in drug development against pathogenic disease is total inhibition leading to the to the death of the pathogen. So in this case, the target should be located in a critical step of a metabolic pathway, and its inhibition should consequently kill the pathogen. So in this case, drug targets should be unique so that no other pathway can suppress the impact of that inhibitor. So target selection is one of the most important process, especially in structure-based drug design. So the physiological effect of the drug should be clearly defined as possible, and it should be specifically bind to the target protein in order to minimize other kind of undesirable side effects. So once the target is identified, then for structure-based drug design, the next step is the accurate structural information that need to be gathered. Okay, so knowing a protein structure is important to understand how it functions. And recently, we have X-ray crystallography, we have nuclear magnetic spectroscopy, NMR spectroscopy, we have homology modeling and comparative modeling. We have free available softwares for homology modeling and comparative modeling, and we also have one of the most recent successful technique for structural biology, which is cryo-electron microscopy. So I will just briefly mention what are these. So X-ray crystallography, it's an experimental technique in which X-rays are diffracted by crystals. So the drawback here is the protein has to be crystallized, only then the data can be collected. So one of the issues with structural X-ray crystallography is that not many proteins, especially membrane proteins, were successfully crystallized in the beginning. But now, recently, we have many other optimized techniques in X-ray crystallography, which allows most of the proteins to be crystallized successfully, including complex proteins like G protein coupled receptor. So X-ray crystallography will give a high resolution 3D structure where the coordinates of the atoms will be used by the computer to construct the protein structure. The next is NMR spectroscopy. So NMR spectroscopy, it uses magnetic fields and electromagnetic radiation, and it determines the structure of a protein in solution state. NMR usually it's used to characterize the structure and molecular dynamics of target or ligand molecules. But the drawback of NMR is it cannot be applied to large proteins. NMR is usually much more susceptible for proteins that are smaller than 30 kilodalton. And we have homology modeling. So homology modeling, it usually will find templates based on the sequence of the protein. And usually if the sequence identity is 30% or more, we can get good templates which can be used to model our protein based on that template. And recently, we have many free softwares which is available, which can give you the structure within minutes. So, apart from all this, we also have another emerging technique, which is cryo-electron microscopy. So, one of the most um, wanted techniques now in current time is cryo-electron microscopy because its limitations are all improved. Initially, one of the limitation that cryo-electron microscopy had was it couldn't be applied to large proteins. But now, with recent advancements, cryo-electron microscopy has shown to be successful to determine proteins which range from 20 kilodalton to 200 kilodalton with high resolution. And the advantage of cryo-electron microscopy over X-ray crystallography is that for cryo-electron microscopy, the protein has to be only in the solution state. So crystallization is not necessary, and the protein structure will probably mimic the biological condition. So this are some of this are not just some, these are all the techniques which is available right now to accurately study the structural information of a target protein. So once the target is identified and once the structure is studied, the next step is, of course, to identify the binding site and computational drug design method. So after structure of the target is determined, the binding site, which is also known as the active site, it needs to be identified. So the ligand is a small molecule which can usually be ingested orally. We have antibodies and nanobodies, but most of the drug design, especially computer-aided drug design, it usually prefers small molecules as the ligand. So the binding site is it's the binding site of a protein is usually a hollow cavity-like structure, and it usually has a lot of hydrogen bonds to hydrogen bond donors or hydrophobic characteristics. So when the ligand binds to the target at the binding site and is capable of inhibiting the target, then the ligand is considered a lead compound or a lead candidate. So this is for the identification of the binding site. As for the computational drug design, so the goal of computational studies, it's used in drug design, is to evaluate the inhibitor's binding complex. So after identifying the possible binding regions on a target structure and the potential ligands that bind and inhibit the target, then this complex will be evaluated by computational studies. So computational and experimental methods are followed for finding a good lead. Computational methods for structure-based drug design are usually not mature enough to replace the existing practice, but new approaches and computer programs continue to appear. So maybe in future, computational studies alone will be sufficient to confirm if the lead compound is it's okay or not. So, in computational work, most of the work falls into the categories of de novo design, docking, and scoring. So, de novo design, it involves designing of novel ligands, which is intended to bind to a given receptor with high affinity. So, researchers usually will split the problem of ligand binding into two sections. One is docking, and the other one is scoring. So, for a known target structure and a known ligand, docking usually involves locating the bound configuration of the ligand and the receptor, while scoring involves evaluating the affinity of the ligand given a particular bound configuration. So, docking and scoring are complementary methods in structure-based drug design to finalize if the lead compound is it's okay and it can be proceeded to the next step. So, the final step is, of course, to evaluate the potential lead candidate. So once the ligand has been successfully identified, so this ligand is then it's called a lead compound, and it must be evaluated for binding affinity before proceeding to the preclinical trials. So for this, biophysical analysis are usually used, and in this they will check the bioavailability of the lead. They will check the chemical and physical stability of the lead, and they will also check the affinity of the lead. So uh, so uh, we have looked into some basic information on computer-aided drug design and its component, which is structure-based drug design. So next, I want to briefly talk a little bit on structure-based drug design for G protein coupled receptor. So GPCR, it represents the largest protein family encoded by the human genome. It is located in the cell membrane, and they transduce extracellular signals into key physiological effects. Their endogenous ligands includes orders, hormones, neurotransmitters, chemokines, and etc., varying from photons, amines, carbohydrates, lipids, peptides to proteins. So GPCRs have been implicated in a large number of diseases such as diabetes mellitus, type 2 diabetes mellitus, obesity, depression, Alzheimer's disease, cancer, and many other more. In human, we have uh, which is already identified to date, there is around 826 human GPCRs, and out of this, approximately 350 non-olfactory members are regarded as druggable targets, and 165 of them are validated as drug targets. So the latest statistical data indicate that 527 FDA-approved drugs and approximately 60 drug candidates currently in clinical trials all targets GPCRs. So starting with crystal structure determination and accelerated by cryo-EM technology, the 3D structural studies on various GPCRs in complex with ligands, in complex with their G proteins and aristines, uh, it significantly deepened our knowledge of molecular mechanism of signal transduction. So novel insights into ligand recognition and receptor activation for GPCR offers new opportunities for structure-based drug design, specifically for GPCR. The Structure of GPCR is a crucial determinant for understanding the molecular mechanism underlying ligand recognition and receptor activation. It provides the foundation for the drug discovery process. Uh, GPCRs were first the structure of GPCRs was first solved using X-ray crystallography. And the first crystal structure which was solved is it's of rhodopsin protein, which is a GPCR from bovine eyes, which was solved in early 2000. And from then, tremendous of efforts have been made, and still elucidation of GPCR structures remains challenging due to several bottlenecks, which includes low receptor expression level, difficulties in extraction, high flexible conformation, and lack of crystal context. GPCRs, they have quite a big amount of intrinsically disordered region, which it's usually a drawback to crystallize this kind of proteins. So when this happens, cryo-EM electron microscopy emerged as a savior to start solving GPCR structures without even having to crystallize them. So now most of the GPCR, almost most of the common GPCR structures are readily available in database, and it's been highly used for structure-based drug design. So the revolutionary development in the structural determination of GCPR, GPCR, it enables the researchers to identify the key sites, which is the active site, and the important interaction which is responsible for the target function, which allows them to shift their focus from merely affinity enhancement to the refinement of pharmacological functions of the drug. So, so, so it is noticeable that the dynamics of GPCR are related with its active or inactive forms. So the binding pocket of GPCR is usually highly flexible, and the geometry differs between active and inactive form. So this increases the diversity of identified ligands that can either stimulate, reduce, or inhibit the receptor activation and signaling. Until most recently, GPCR drug discovery was focused on targeting the orthosteric binding site due to the limited understanding that the GPCRs can only exist in either active or inactive forms. But then now an increasing interest is gained on targeting the allosteric side of GPCR. So this is the state where the binding of drug stabilizes the receptor in a distinct conformation that can actually modulate the binding action of an agonist or antagonist. So I was interested in building a solid foundation for the discovery of drugs that modulate specific interactions between biomolecules for GPCR. So this was my postdoc study in the University of Tokyo. So we decided to produce a new modality, a new drug modality for GPCR. So we decided to fuse two different kind of drug molecules. One is a small molecule, which is usually small in size, but then it has low affinity and low selectivity. But since it is small in size, it will usually find the hydrophobic pockets of the GPCR, and it can bury deep within the pocket. And we wanted to fuse these small molecules with nanobody, which is large in size, but then it has high affinity and high selectivity. So our hypothesis was by combining these two, by combining nanobody with small molecules, the new modality which is produced uh, uh, will be a drug with high specificity and high affinity towards GPCR. But unfortunately, I couldn't complete the study. But nevertheless, the new advancement which is happening in structure-based drug design for GPCR right now, hopefully more better drugs with more specific targets and more specific targets with higher affinity are available in future. So finally, I would like to talk about future perspective of structure-based drug design. So recently, artificial intelligence has been receiving quite a high attention in every field, and this includes structure-based drug design. Studies have indicated that the combination of artificial intelligence and machine learning with structure-based drug design techniques, it will emerge as a new tool with immense potential in the discovery of therapeutics. So integration and refinement of big data by artificial intelligence, it is a clear direction to guide both virtual and experimental screening efficacy of therapeutic agents, which is highly efficacy with new scaffolds and novel chemotypes. So that is actually the end of my talk today. So thank you for listening. So I will give the floor to Dr.
Thank you, Dr. Menega. Nice explanation about the structure-based drug design, the role of this research in the in the drug designing, where it plays a vital role in reducing the time and money to predict the possible drugs, because in every step to understand the structure of the protein, and if the if the what do you call crystal structure is not available, how to overcome that one, and also pharmacore based possible target design, not the target, the drug design, everything, and including the recently you mentioned that the electron microscopy, so where it will be solving all the issues for the proteins, where which proteins which is cannot able to crystallize. I think with this, I think most of the proteins can be studied, and it will be ready for the drug discovery. Okay, I think it's a very nice explanation, Dr. Menega. So thanks. And if anyone having any questions to ask to Dr. Menega, I think you can fill the chat box. Okay, there is one question from Dr. Chen. Prof. Chen, what is your opinion on the genetic polymorphism in your study? You are on mute,
Yeah, sorry.
Dr.
So one advantage of homology modeling is where you can actually put in the mutations when you're doing the modeling. That is the reason why I say doing structure-based drug design is advantageous. even before you apply that kind of mutation in experimental condition, you can check whether this kind of mutation works or not. Or like for instance, in genetic polymorphisms case, it's mainly about the mutations. So if let's say we are considering that if this drug will be efficient against mutated protein, then we can apply the mutation in our homology modeling when we are doing the docking and anti-stimulation. So in this case, I think for genetic polymorphism based proteins, structure based drug design would be highly advantageous.
I think that's clear. I think Prof. Chin's question and Prof. Pai mentioning the very informative. So, any other questions to Dr. Menega? So, if there is no any further questions to Dr. Menega, so we will both speakers well done. Okay, so we will close today's CME talk. Thank you everyone for attending, and thanks both speakers for wonderful talk. So, so we'll see in next 102nd CME talk later. Thank you so much. Have a nice day. Happy weekend.